Morning, everybody, and thanks to Lisa and the planning committee to have me here. It is an honor to be here with you today. And I have been with Creighton. This is my 29th year, and I have also worked closely with nursing, respiratory therapy, and medicine over the years. And during the Steve Carper days, I did teach pharmacology at Midlands to the respiratory therapists, so important part of my practice. And I was quite, this is like the worst year of potholes I've ever seen in Omaha, right? And, my students are losing their wheels, and I have to believe them that they're late, and all this. And on the way over here, I did see a 3-bedroom, 2-bath pothole on Center Street. So, unbelievable. Okay, so our objectives, what I'd like to share with you is some of the new respiratory products and new dosage forms. So all of you that work with patients with lung disease, it's important not only to know the new stuff, but also improvements in dosage forms. And we'll kind of take a look at the indications and side effect profile. We cannot do, obviously, a comprehensive therapeutic review in the time we have, but we can get through these products. And then take a look at some of the new evidence-based treatment guidelines that would affect the care of respiratory patients. And I have no conflicts of any kind with any of the material I'm presenting today. So I like to actually engage the audience with active learning. So the first question to you is, and you didn't know this, so it's coming anyway, how many meds were approved last year? So maybe we can do a show of hands. Was it 22? Okay. Was it 33? Okay. 59? Okay. Or 67? So I think the majority you've got it is actually 59. So it was a very busy year for the FDA. Okay, one of our newer LAMA agents has been around for over a year now. Glycopyrrolate is available, in a nebulizer solution known as Lonhala Magnair. And what is the dose of this agent? Is it a once-a-day nebulizer treatment? A, nobody's raising their hands. Is it a twice-a-day nebulizer treatment? Who thinks it's twice? Okay. Some of you have already gotten tired raising your hands. Is it C, 3 times a day? Okay, a few C's. And how about D, as needed? Okay, so the correct answer is actually twice a day. And the reason I keep up with all these, myself personally with all these things, I go on rounds in the ICU with the Creighton academic pulmonary critical care physicians, and one of my colleagues that you'll see later today is Lee Morrow. But I also spend time with them in the clinic, and my role is to actually have patients understand how to use their inhalers because they get very little education opportunity. And recent evidence suggests that probably 80% of patients don't use their inhalers correctly. And okay, one new med that got approved last year. So as a health professional, you get asked about all kinds of meds. So the marijuana derivative, cannabidiol, Epidiolex got approved. So what is it approved for? Is it A, seizures? Raise your hand. Okay. Is it B, for pain? Okay. Is it C, for end-stage COPD? Okay. Or D, obstructive sleep apnea? Okay, so this, of course, is different than THC, so there's no euphoric effects for it. And it's only approved for individuals under the age of 2 for Dravet syndrome and Lennox-Gastaut, so it's seizures. Okay, so there is no other, right now, application for pain or any respiratory disease. So I just threw that in there. Okay, looking at the approvals from last year. So 59 new drugs. The average over the last 10 years or so is only 33. So what happened last year was that there were first in class, about a third of them were drugs with unique mechanisms, okay, and some of these will be respiratory. Orphan drugs is like that marijuana derivative. So this is for a limited section of the population that has like 200,000 or less, Americans that fit this definition. So there's 58% were orphan drugs. So Congress has kind of been on these drug companies about, you want special, approvals, and there's not a lot of money to be made by the companies for these very rare diseases, so a lot of them are priced very extensively. They're very expensive. And there's almost 7,000 rare diseases that have been identified. So that affects about 30 million people. Okay, breakthrough, what does that mean? This is evidence that suggests it's a substantial improvement over what we have available. So about a quarter of them were significant breakthrough. Fast track, these are drugs that met unmet medical needs. Again, so a lot of these treatments didn't really exist before. That's 40%. Priority review is an important thing. So this is an agent that's given a review that's suggested to provide a significant advancement in medical care. And if to get a priority review, I didn't include this in your data, but those of you that work inpatient know that patients taking rivaroxaban and apixaban have a lot of bleeds. So one of the products that was given a priority review was Indexanet. This is like a factor 10A reversal agent. So we didn't really have that before to target those new anticoagulants. So that was like an example of a priority review. Accelerated review means that it was approved before all the clinical data were in, but the FDA would continue to collect data from the company because the clinical benefit was such that it would be a significant breakthrough. So that happens a few times. A lot of those are chemotherapy-based treatments. First in cycle means that they're approved without additional delay. That means when you fill your application in, and obviously you're thinking I can't do my math, but 56 out of 59 is 95%, not 45% on this slide. So the majority of these applications went through with the FDA asking no further data. So that was an important thing. So they used to say that it would take about 6 semi-truck trailers full of data now in the old paper days for your FDA drug application. Those of you that worked in clinical trials or some investigational studies know the volumes and volumes of data that occurs with that. Now these are done electronically, so it's a little bit faster pace. And it's also important because you're thinking, well, I live in the United States, but I hear about all this stuff happening in Canada and China and the UK. Well, of all the agents that were reviewed last year, 71% of them were approved here before they were approved anywhere else. Some meds are approved other places first, and I think the FDA is appropriately cautious about some things because we want to make sure that we don't put patients at risk if we don't really know everything about that particular risk. Okay, so here's again our summary of what happened over the last 10 years or so, and you can see last year was a big breakthrough year. As far as inhaler techniques go, so I get to work with patients with inhalers, and what I find talking to the pharmacy students that work in the pharmacy, they all the different community pharmacies, they can't take them out of the box. They come in wrappers and they come in boxes, and if you open them up and they're not billed through insurance, who's going to pay for that? In the hospital now, there's so much de-emphasis on using inhalers that even if somebody gets a new inhaler, you can't have a respiratory therapist talk to the patient about it because what are they getting in the hospital? Nebulizers, for the most part, right? Why are they doing that? It's less expensive, right? And it's not possible to stock all the different inhalers that are available. So it's coming to the point where, a lot of us don't have good, consistent experience with holding the inhalers or knowing how to use them. So I've summarized on this slide here some of the important places to look. So the CDC has some great videos on using inhalers. Also, the Allergy and Asthma Network does. That's the one that actually, Allergy and Asthma Network, they put out a single sheet, which is a summary of all the available inhalers. Some of you may have seen that. It's very important to have in the clinic. ISMP has some great videos also. There's a website called useinhalers.com, and then some of the specific product websites. So I'll often refer patients to that specific product website if they are so interested in doing that. And it surprises me how many even older patients now have these higher tech cell phones that are beyond what mine can do. So, okay, so when we think about respiratory pharmacology, we break our categories down. So we have our beta agonists, we got our short-acting and long-acting, we have anticholinergics who are now becoming more of a standard for, especially for COPD. We have our short-acting, which have been around. Now we have more additional long-acting agents. We got our combined SAMAs and SABAs. We have our combined LABAs and LAMAs, again, which is another growing category of meds. The biggest category of med of all is inhaled steroids. Okay, if you look across the board, the biggest category of inhaled meds. Then we have our combined LABAs with steroids, which is a very competitive formulary class. And then we have, over the last 18 months or so, we have a triple combined product from one company, and there's another one that's very close to being marketed. So what happened recently with the short-acting beta agonists? Well, we have one new product, and we have a couple generics coming. So if you look at all these products, your albuterol has 3 different trade names, Preventil, Ventolin, and ProAir. Same dose for all of these. Most patients prefer to have the Ventolin or the ProAir because it has a dose counter. The Preventil product does not have a dose counter. But the new product that we have is actually the ProAir Digihaler. So that was approved last year. It's much the same as the RespiClick delivery system. However, this was known as the first smart inhaler. So many of you may have heard about that. I haven't yet seen it available, but it was approved. And of course, we have 2 levoalbuterol formulations. So this ProAir Digihaler, also known as the first smart haler, actually has a built-in chip that connects with an app. And this app can be downloaded, and you can store data regarding the inhaler use and inhaler events. And that can be shared with the provider. So this is like the first time technology has really been applied to an inhaler. So it's much like the previous RespiClick. It's sort of a dry powder inhaler where it takes an inspiratory force to deliver the product into the lungs, but this smart technology probably has a lot of application. So this type of inhaler, you don't shake it before you use it, no priming. You can wipe out the mouthpiece. It does have a dose counter. Patients love the dose counter. And even if you look at the expiration date on inhalers, realize that once you take it out of the pouch, which is inside the box, this manufacturer recommends that 13 months after you take it out of the pouch. Some of the other products, even though the data on the inhaler might say a couple years, it's only good for like 6 months out of the pouch. So keep that in mind when you're talking about patients and the best optimal use of inhaler should follow the manufacturer's directions regarding the stability of the product. Okay, earlier this year, Teva, which is one of the manufacturers, they make ProAir. They say that they're going to make a generic albuterol. Okay, so the same company is going to make another inhaler and call it a generic. Okay, you wonder why they just couldn't lower the price of the trade name product, but now there's another approval, another company, since I put these slides together and turned them in to Lisa, there's another product going to be out. It's going to be a generic for Ventolin inhalers. And so, the only one will be Preventil, which doesn't have a generic. So who would best benefit from a generic? If you have a patient that's on the state Medicare plan with their insurance, there's probably a contracted inhaler already. Many of these insurance plans, companies already have contracts with some of the trade name inhalers. So it's really hard to know who's going to benefit from a lower priced inhaler. To me, it's probably going to be that patient who's paying cash for it, who otherwise can't afford it. And some of our combined LAMA steroids, they cost over $500 just to set on the pharmacy shelf, and that's the retail price. So some of these inhalers are pretty expensive. Okay. Take yourself back to 2011, okay? The roads in Omaha were better then, okay? So what do we know about Primatene Mist, right? Why did it go away in 2011? Anybody remember? It was epi-based, but it went away for a reason. Exactly. It was not an HFA formulation. So the Montreal Protocol back in '86 required all the manufacturers to move away from a CFC or chlorofluorocarbon to the HFA, and this company couldn't do it. So they had to pull it off the market. Well, they came back now, and it was approved last year, and now you can buy this again over the counter. But this has caused a lot of concern from a lot of our professional societies. So it is labeled for the intermittent treatment of asthma. The retail price is about $29.99. And what some of these groups are saying to us as professionals is that, racemic epi has never been recommended as a standard treatment. So this is a 0.125 milligram of epi, and it's 160 doses. So the patient who would use this optimally would be 1 to 2 puffs every 4 hours, but no more than 8 in 24 hours. And again, they can walk in, if you think of all the different retail outlets that sell over-the-counter products, they can get this without talking to any health professional at all. That's the concern. And if they're really having severe asthma and they're using this, they're not doing anything for the underlying inflammation, right? So that's the real concern. So Allergy and Asthma Network, the American College of Allergy, Asthma and Immunology, American College of Chest Physicians, American Lung Association, and the American Thoracic Society are all completely opposed to this. And they challenged the FDA commissioner for actually approving this because they thought that this is a product that's probably not going to be used optimally by patients who really need better control and better supervision by their health professional. So you have to activate it and clean it every day, which I doubt will happen. You have to shake it and spray it once in the air before use. And if you're using it more than 8 puffs in 24 hours or 2 attacks per week, which is on the labeling of the product, but which patient is going to read that? Probably none. So there's some concern about it. So remember, when you're doing your medication histories and talking to your patients, ask them, because they could be, if they can buy stuff over the counter, they don't think it's a real drug and it doesn't count on their med list. Okay, so the long-acting beta agonists, there really has been no change here. The most recent addition to this list would be the Olodaterol, which is an ISI formulation. That's the most recent product. No change in the short-acting anticholinergic agents. So one of our, this same product is a nebulizer or metered dose inhaler, been around for a long time. The LAMAs, there have been some recent changes here, and that would include the ability to give these as a nebulizer. So remember, there's 2 strengths of the tiotropium Spiriva Respimat. The 1.25 lower strength is for asthma. That's got a different color top than the COPD dose, which is a little bit higher dose. Also, the glycopyrrolate Sebree Neohaler is available now. This has been available for over a year. I think that the Novartis Neohaler products are probably it's a capsule, but I think it's one of the most technically difficult inhalers to use. I've seen a 35-year-old pulmonologist have trouble using this one, so I can imagine what a patient would do with that. So the kind of the breakthrough with these has been the nebulizer solution. So the question I asked you earlier about the glycopyrrolate formulation, this comes with its own nebulizer device. It's actually used twice a day. It's a 1 ml vial, and it has to be used with this portable handheld nebulizer which comes with the product. Last year we saw an approval of revefenacin, which is a derivative, and Yupelri is the trade name, and this is a nebulizer that can be used in any standard jet nebulizer. So it's 3 mLs, just used once a day. So the Lonhala Magnair was the first LAMA approved, and again, you have to use this Pari Pharma Magnair eFlow system. It's only been studied, and it's only considered to be effective by use in this system. So like any LAMA, when you expose it to a patient, you could have anticholinergic side effects, and they could be additive with any of the other meds that they're taking. So here's a picture of what that glycopyrrolate system looks like. Some of you may have seen this before, but it's a complete package that the patient gets with their prescription to the pharmacy. They get this charger and nebulizer, and it can run while it's charged, and it's pretty quiet. But you're limited to this, and you have to carry it around if you're not at home, and it has to be used in this particular device. The revefenacin is just once a day. It's given over about an 8 to 10 minute period, and it can be used in any standard jet nebulizer. So again, as a long-acting antimuscarinic, it's going to cause urinary retention. It does have some drug interactions, so if you use something like rifampin, that can increase the metabolism. Cyclosporin would decrease the metabolism, and then any other anticholinergics that they're taking will have additive, potential effects on dry eyes, urinary retention, and it really shouldn't be used in patients with advanced liver disease. So this is out, and I believe it's being sampled in clinics. As far as the combinations of SABA, there's a few products there. Probably our go-to agent for most of our hospitalized patients is the Duaneb product. As far as the LAMA LABAs go, these are becoming increasingly used in patients with COPD because not every COPD patient needs a steroid. I think I'm seeing a lot of these across the board for a lot of patients. So we have the newer generation beta agonist vilanterol combined with umeclidinium. We also have tiotropium with oladaterol. Glycopyrrolate is with indacaterol. So this is another neohaler. And then we have the glycopyrrolate with formoterol, which is Bevespi. So that one's the only metered dose inhaler amongst this category. Steroids, are again the most widespread use, and the only new product to speak of actually is with beclomethasone. So many of you remember the Qvair HFA inhaler. It's been around a long time, and it's actually been reformulated. So the product technically was discontinued in August of 2017, but there's still some circulating inventory on different shelves of pharmacies, but it's really going away to a newer generation product. So this is the old product as you knew it, and the new product is now with a different delivery system. It's called a ReadyHaler. So no shaking, no priming, you can clean it, does have a dose counter, and it has been FDA approved in 2017. So as these pharmacies are trying to order this now, they're going to get this newer generation trade name Qvair product. And it's interesting, it is the only breath-activated inhaled steroid. So the patient would have to use their own inspiratory force, to deliver the product into their lungs. And here's the remaining products from inhaled steroids. So there is, some alternative products. So we have the fluticasone propionate is the Armon Air Respiclick. It's supposed to be a lesser expensive product compared to the Flovent product, although I think it's had limited availability. And here's the remaining steroids, so no change there. Now, one of the big competitive categories has always been the inhaled steroid LABA combination. So this could be primarily your asthma patient. It could also be your COPD patient. But some of the newness about what's happening here is that, again, there's an alternative to fluticasone salmeterol. This product's been technically labeled for a while. It's called the Air Duo Respiclick. It's not totally equivalent to the Advair formulation based on the strengths or similar, but again, that product has had limited availability. So I haven't really been able to compare the cost of it because I haven't seen it. But what did get approved earlier this year was a particular generic to the original Advair Discus. And that 500 strength Advair Discus costs the pharmacy like $500 to keep it on the shelf. So this product is different. It's made by Mylan, and they've actually tried 3 or 4 times to get a different generic approved, and they did now. It's called Wixela Inhub. Okay, they didn't ask me about the name, but that's what the name is. So if you're a respiratory therapist, there's something different about this product. The Advair Discus, you'd administer it horizontally. This product you hold vertically when you use it. And so it's also unique in the sense that GSK, the trade name manufacturer of Advair, also launched its own generic just weeks after this one was approved. But the wholesale acquisition cost for this Wixela Inhub is going to be about 70% less than the Advair, which is quite sizable, and about 67% less than the generic. That means that the generic isn't going to be priced that much less than what the trade name is. Probably as time goes on, it will be. So this is just a different type of delivery system. So there aren't too many meds that we actually use, in the vertical position. And then, of course, we have the triple combination product. This is GSK's product, the Trelegy Ellipta, which is heavily marketed on the media, on TV, etc. But AstraZeneca also has a product which isn't too far behind in getting itself approved. So like most of the Ellipta products, no shaking, no priming. Patients like it because it has a very easy-to-see dose counter. And this is where the manufacturer will tell you that if you take it out of the foil pouch, it has a 6-week, good use date, or of course when the counter reads 0. So keep that in mind. The best efficacy is determined by the manufacturer. It's not necessarily the expiration date on the product itself. And this was approved back in the fall of 17. Okay, moving on to some other respiratory meds. One product that did get approved last year is amikacin. So many of you have seen inhaled tobramycin, right? It comes in a lot of different dosage forms. But amikacin is another aminoglycoside, and this one is approved only for patients with MAC, which is Mycobacterium avium complex, and it's sort of an add-on therapy. These patients with MAC often have bronchiectasis, frequent infections requiring IV antibiotics and even hospital stays. But this amikacin right now has only been studied for refractory MAC. So it's a 590 milligram, 8.4 ml nebulizer treatment that's done once a day. And again, it's been studied with a Lamira nebulizer system, and it's about 15 minutes or so. It's recommended that patients get pre-treated with a bronchodilator such as albuterol. And because it has just limited application right now, there is a box warning, for concerns primarily with the disease state of MAC. So I think it does represent a nice advancement in therapy. And for those of you that do see patients with MAC, the new guidelines are actually going to be published any day now, and they will include this as a recommended treatment. So here's the trade name and the special inhalation device that comes with it. That should be used with it, and patients will likely be able to do this in the outpatient setting. Okay, another inhaled product. You've all heard of levodopa, for Parkinson's disease, right? But it was approved last year as an inhalation powder. And so you may be asked to help a patient in the hospital if they have this as a home med. So it's 2 capsules. Used up to 5 times a day when patients start to have a little return of their symptoms, their tremors, etc. So these capsules can only be used with this trade name, Inbra breath-activated inhaler. And like most breath-activated inhalers, when the patient inhales, you'll hear kind of a little whirling sound. That's normal. Side effects, as you would expect with any dry powder inhaler like this, could be cough and nausea. So just to let you know, some of the Parkinson's treatments like this will now are going to be delivered as an inhalation therapy. Okay, you've all heard of oseltamivir or Tamiflu for flu. Last year, or actually earlier this year, baloxavir or Xofluza was approved. And this is primarily for outpatients. It's actually being studied right now. We're doing a study at Creighton looking at this for the use of acutely ill patients. But the normal course of oseltamivir is for how many days? Anybody had to take it? There's a big influenza. 5 days, right? This is a single dose. So instead of taking it, so as a health professional working with respiratory patients, it's good to know about this product. So it works the same way for the treatment of acute uncomplicated influenza, but they have to have their symptoms last no more than 48 hours. So if they show up fairly promptly, you can give them a single dose of 80 milligrams. And you have to be careful because it could be chelated with dairy products and not absorbed real well. So also iron products could also affect its absorption as well too. Single dose. And they're looking at it, as I said, for the hospitalization of patients with influenza. And we've seen a lot of these COPD patients with influenza end up on ventilators. This has been a pretty tough influenza season. So maybe in the future this product might be helpful for them. For those of you that work with cystic fibrosis, tezacaftor, ivacaftor are now combined into a single product. It's called Symdeko. So this is a fixed dose combination for individuals over the age of 12 that actually have the F508 DEL mutation. And this is common in more than 50% of the patients in the country that have cystic fibrosis. So combining this treatment does improve pulmonary function. It is rather expensive, like most of these treatments for cystic fibrosis, but it is available as a dual ingredient product. Okay, the next topic is going to be, asthma drugs. Now, patients that have severe refractory asthma, those that require multiple hospitalizations, are already on high doses of steroids, they might even be on different oral steroids. There's some new treatments that have been available for the last few years, and patients who are going to benefit best from these are those patients with frequent exacerbations and also patients that have a high eosinophilia count. So you might be hearing about more emphasis on eosinophils as a marker for inflammation. Also, patients with the asthma COPD overlap, right? We see a lot of those patients who have high eosinophils might be put on some of these agents also. So the one that got approved last year is dupilumab or Dupixent. I've actually seen some patients on this already. I didn't make a slide of the different mechanism because I thought you might have been asleep by this time already in the lecture. So this is an IL-4 and an IL-13 antagonist, so it will inhibit the inflammatory cascade. It's a pre-filled syringe that patients can dose themselves. So it's dosed every couple weeks for individuals over the age of 12. If you compare it to some of the other agents, benralizumab is an IL-5 antagonist, also a pre-filled syringe. It can be dosed after your initial titration every 8 weeks. Mepolizumab or Nucala is an IL-5 antagonist, single-dose vials. This is another sub-Q injection. And then reslizumab or Synquare is an antagonist also, but this is an infusion. So I think, and that one's approved over 18 years of age. And I think you're going to start to see these as part of a comprehensive management plan for patients that do have severe asthma or for that COPD overlap. And you ask yourself, what evidence is there for these agents and what makes these patients identified as a good candidate? And what we know from the GINA or the guideline, the international asthma guidelines, is that patients that have high eosinophil counts, they've had exacerbations in the last year, they have adult onset asthma, and they have nasal polyps, these are probably going to be good candidates. And insurance companies, I can tell you what I see in the clinic, they're approving these patients with poor control, even with eosinophils as low as 150. So they have to be at least 150, and what product the patient gets on a lot of times will be determined by what contract their insurance company has. So if you look at the Global Initiative for Asthma, or the GINA guidelines, of course, we start all patients on a short-acting beta agonist, and then they get put on a low-dose steroid as step one. If they still have symptoms, you can add like a leukotriene modifier like montelukast, and then if you need to step up still, you could add a steroid or LABA, like that big category of meds that I showed you. Step 4 would be advancing the dose of your steroid. Step 5 will be intermittent oral steroids. Now here, if they have a high IgE count, that would be like omalizumab or Xolair could be used in those patients. Also, there is a role here for the anti-IL-5s. So keep that in mind. In some patients, and there's growing evidence now that tiotropium or Spiriva could be also helpful, and that could also be considered as an add-on therapy. I don't know if you see that very often, but occasionally you will. So this is where this IL-5 category fits in, as those patients with severe uncontrolled asthma. Okay, the GOLD COPD guidelines were also updated last year. This is also important to know as far as treatment goes. There's an important role for respiratory therapists. And what the guidelines tell us is that pharmacologic therapy, for COPD, obviously is used to reduce symptoms, reduce the frequency and severity of disease. However, there is no conclusive evidence from any of our trials that medications for COPD actually modify any decline in lung function. So what we try to do is match the best drug with the patient, using the guidelines help us determine the severity of the patient's COPD and match that treatment. You also want to be mindful of the patient's economics and insurance and try to pick the best treatment that matches them and balance that against side effects. So this is updated usually once a year. It was updated last fall. And one thing that has remained clear is smoking cessation. And probably every hospital I've worked in, the biggest educators of smoking cessation are respiratory therapists. And we know that smoking cessation has the greatest ability to influence, the history of COPD. So we can't say that enough. And these are just some strategies to help the patient quit. They are emphasized throughout the GOLD guidelines, and just an emphasis there that we should be better about this. So I'm actually a lead author of a guideline for the American College of Chest Physicians, and I did the guideline for cough and the common cold. We published that in 2017, and the one I have right now that we're nearing finished, we're going to send in for publication, is actually cough with chronic bronchitis. So we all see these patients with chronic bronchitis. They get various cough treatments. So what I can tell you, after 2+ years of going through all the evidence in the literature, there's no pharmacologic treatment that it performs better than a placebo-controlled trial for cough associated with chronic bronchitis. And so we don't have a lot of positive things to say about the available evidence, but one thing with a guideline, even if you don't find something, you should still share the collective body of evidence as it exists today. So I'm working with somebody from like Harvard and from the FDA. They're physicians that are on this guideline with me, and I guess we were kind of disturbed to find out there's just very little evidence you can do pharmacologically or even non-pharmacologically to help patients improve their cough symptoms of COPD. And all goes back to getting people to stop smoking. That's probably the biggest thing that we can all do to help with the advancement of that disease, is stopping smoking. Okay, another concern that we have, at least that I have, as far as medication safety goes, is common canister policies. Anybody ever heard of this? I can tell you that University of Colorado, and there's some hospitals in Iowa that do this. And so you have these bean counters in the pharmacy world, and they look and say, we're using a lot of inhalers, but patients have a 3-day length of stay, but yet we have to buy this inhaler that's a 30-day supply. So we end up throwing it away all the time, and we're not using it like we should. So why don't we try to avoid costs and waste by using the same inhaler on the same unit, and we'll just give each patient a different spacer. Does that sound like a good idea? Is it being done? It's being done. So this policy, and they've shown that they're saving hundreds of thousands of dollars, and they take the single meter dose inhaler, which is carried in the pocket of a respiratory therapist. That's the same pocket that probably goes to lunch and everything else. But throughout a nursing home ward or a hospital ward, and each patient has their own spacer. And really the safety concern of this, really is about the proper cleaning of the inhaler and the spacer between use. So I was asked by the American College of Chest Physicians to write an article about this, which I did, and I cited it here for you. So I summarize all the places that are doing this, and this isn't new. It goes back to the 80s, but it's sort of, with all of our economics and everything, it's sort of come back again. And and I'm glad that the hospital network that's affiliated, with our teaching center does not do this. So I think the safest thing to do would be if you can't really get them the inhalers that they should be on. We can't start new patients with new inhalers in the hospital because it's going to be too expensive. So use nebulizer treatments. So that's what I try to recommend, is nebulizer treatments are much better than not having access to the inhaler, and it's much better than sharing an inhaler with a mouthpiece. Now, certainly somebody with isolation or in an ICU bed or all that stuff, you would not want to share those inhalers, but all it takes is one misadventure. And before engaging in such things as a common canister policy, you really should talk about it with your infection control people, your risk managers, the P&T committee, the pulmonologist, the respiratory therapist, the med exec committee, etc. Even the body that provides professional liability insurance to your workers. And I ask our infection control people, about would they would ever endorse such a policy, and they said absolutely not. I can't tell you what else they said, but they said absolutely not. All it takes is one infection, and I think it could cost the system millions of dollars. And the liability is just not worth it. So in this day of economics and limited formularies, etc., I think the most effective use of our inhalation treatments for our asthma and COPD patients is going to be nebulizers. What that means, though, is that, nurses, respiratory therapists, pharmacists are not getting to see the inhalers, not getting to use them. Patients get put on a new treatment. They have to wait till they go to their pharmacy. The pharmacy won't take it out of the box. Nobody's giving them instructions. And our 80% of patients that aren't using inhalers right is getting worse every year. So that's my observation over the last several years. Okay. I've got a couple questions for you, and then you can ask me some questions if you like. So a generic equivalent exists for which of the following steroid LABA products? C. Okay, revefenacin was approved last year. In which patient population does it have the best utility? Is it for the acute treatment of asthma? Raise your hand. Okay, is it for the acute treatment of COPD? Okay, we have 1 or 2. Is it for the chronic treatment of asthma? No? You all getting tired? Okay. Is it for the chronic treatment of COPD? Okay, yes, that's the right answer. So it's chronic treatment, it's not acute treatment. And again, the benefit of this product is it can be used in any standard nebulizer for the patient. Okay, so the new treatment for MAC is the addition of amikacin or Arikayce as a nebulizer treatment, aminoglycosides. So how often is this treatment given? Is it once a day? Yes, okay. Twice a day? No. 3 times a day? No. 4 times a day? You're getting colder. So you were right when you say the correct answer was once a day. Okay, I know that's a lot of material that we covered, but does anybody have any comments, questions, or snide remarks?
I have a question. I've been reading where there's studies that chocolate helps coughs. Taking or eating chocolate. Have you heard of this?
Yeah. So the question is, can chocolate help cough? And there is some literature on this. It's not placebo-controlled literature. And as a panelist on the cough guidelines, the last iteration of the guidelines were published in 2006. And so since 2014, we've actually published 20 different chapters and all these different categories of cough. So I encourage you to go to chestnet.org and look at the clinical guidelines. You can have access to all the cough guidelines that we've published so far. But I did the cough and the common cold, and we looked at all of the, all the non-traditional remedies, etc. But we could not make a recommendation based on chocolate because of the lack of scientific evidence when we look for placebo-controlled trials. But anecdotally, it's one of the things that you hear about that that's passed on from family member to family member, etc. So there is some evidence, but not enough that we could make a recommendation. Now, in a given patient, if they tried it, could it help them? Could. Any other questions? Yes?
Have you heard of cough variant asthma?
Cough variant asthma, yes. And in fact, in the introductory chapter, we put out the guidelines. There were so many different categories of cough that I thought I was aware of all of them, but there's just so many of them. And like, for instance, have you ever used an earwick after you get out of the shower, and you put it in your ear, and you rub a certain part of your ear, and it makes you cough? That's a specific kind of cough for that. That's also defined as a particular type of cough. But yes, there can be some cough variants with asthma. So there is asthma is addressed in many of the chapters. occupational-wise, for sure, in athletes, for sure.
How about with GERD?
With GERD? Yes. There's also eosinophilic esophagitis. So asthma can happen with GERD. And so if you ask the gastroenterologist or the pulmonologist, if they do have eosinophilic esophagitis, which causes cough, sometimes that's actually treated with an inhaled steroid. So that's kind of an interesting treatment. I know some patients that did very well with combined acid suppression therapy and actually a inhaled steroid for that type of cough. Yes?
What are your recommendations, or what do you say to patients when they're trying to convince you to use e-cigs instead of regular cigarettes?
Good question. So the question is about e-cigs versus regular cigarettes. So my panelist on the cough guideline actually works for the tobacco division of the FDA, and I've learned so much from her. I did see this week that the FDA actually has banned some of the additives on the e-cigs for the flavorings to try to discourage the use amongst the adolescent population who seems to have it all the time. And how many times are we at stop signs, et cetera, we see a window of the car go down and this huge discharge of vapor comes out. So I think there's some anecdotal evidence that patients can be helped with it, but I don't know everything about it. I'm not a smoking cessation therapist, but I do know that our smoking cessation people do talk to patients about transitioning from nicotine. This is one of the transitions. I don't know the ultimate data on that, but I know it has been studied to some extent. So you may know more about it than I do, but I think there's attempts to get patients on the vapor products as a way to eliminate their cigarette habit and then further eliminate that from their lifestyle too.
I think with that too, you just don't know what you're inhaling, and so have you heard of popcorn lung disease? There's a lot of alcohol content in vaping, and it can cause obliteration throughout your lungs, like holes, like Swiss cheese. So
yeah, that's the other concern, and since it wasn't really regulated so much. We do see popcorn lung patients and those individuals that work in the factories that make the microwave popcorn, and they can have permanent lung disease from inhaling some of the vapors from the popcorn. So you have to be careful about that. Yes?
Have you seen any patients going back on the old medicines like Theodore or Scopolamine?
Oh, and so the question is, what's the role of theophylline today? And that's a very interesting question. Oral theophylline, anhydrous theophylline, right now is on a significant shortage. And I remember probably back, in the late 70s and the early 80s, it was a drug of choice for asthma and COPD patients, and there are multiple trade name products available. And the most recent data that I have actually seen is that added on for standard of therapy COPD patients, they used to think that it was an immunomodulator. Well, it would have an inflammatory component and decrease steroid requirements. So P.J. Barnes is a pulmonologist from the UK. He's actually come to Omaha and done grand rounds for us. He's probably the biggest theophylline researcher in the world. I think he's the sixth most published man in the world for all the publications he has. And he was the author of this trial. It was just in JAMA. But previously to that, he has shown theophylline to have some benefit with it. But I think because of the toxicity and the narrow therapeutic range associated with it and the drug interaction potential, that most prescribers are kind of shying away from it. And this anti-inflammatory component, may be related to the phosphodiesterase inhibition. But in the most recent trial, which was fairly large, at least in COPD patients, it didn't have any benefit. So, I've worked with pulmonologists that were still theophylline believers. And when we did have, patients, especially with high cervical injuries, C3, C4, you could actually use theophylline to keep people off the ventilator, or if they did have a cervical injury, of course that's where your lung intervenes your spinal cord, you could actually introduce the alphalin to get them off their ventilator requirements. So I've seen that done in the last 10, 15 years. But you just can't get anhydrous theophylline now. It's on shortage. And so the limited use has resulted in a lot of the manufacturers stepping back and not manufacturing it anymore. But I remember that when we couldn't hardly keep it on the shelf. Yes?
I'm going to miss this. What happens if the patient uses their inhaler after the expiration date?
So the question is, what happens if the patient uses their inhaler after the expiration date? There's a good chance it's going to work just fine, but that manufacturer, based on the stability and their data for the optimal use, put that on there. They have those included on there. So, when I talked to the State Respiratory Society, a couple years ago, I put on there each type of inhaler and what the manufacturer recommends for expiration, and it's something that's not followed very closely because, like for instance, some of the LABA steroids, you may use more frequent administration during certain times of the year or following whatever your lung doctor says, and at certain times they may actually have the patient just use once a day of your traditional Advair treatment or something like that. So there's a lot of patients that use it beyond the 6-week period, but the manufacturer is always going to tell you you're not going to get your best efficacy if it's used beyond that date. Clinically, we don't really know. It hasn't really been studied, but it's probably going to be okay unless it's totally out of date. And there's a lot of patients that are, they bring into the clinic and their inhalers are like expired from 2 years ago, and they still have doses left on them. You just wonder how this happens. And they say they're taking their meds. Or you ever pull in a parking lot and you see like in the front of a car on the dash, there's all these inhalers laying there? And when people come in for refills into the pharmacy, I moonlight in a community pharmacy, you can't believe the stuff, what some of these inhalers look like when they come back. It's unbelievable. Yes?
One dose influenza medicine that you avoid milk with.
Yes.
How long you have to avoid milk?
So the question is with that new neuraminidase inhibitor, it's usually a couple hours, like an hour before or a couple hours afterwards, to avoid any cations to assure the optimal absorption. Well, you've been a great audience. Had some great questions. It was a pleasure talking to you. So thank you.